Hello,
Good.
everyone.
We're to get started in about 5 minutes to give additional individuals enough time to log on. Thank you so
Yes,
much.
of course.
Soon. For those of you just joining, we are going to get started in about 3 minutes to give some other people enough time to log in. Thank you so much, and we'll be talking to you soon. Good morning. It is now 9:05 on the East Coast and 3:05 on in Saudi Arabia. We're going to go ahead and get started with today's discussion. Welcome to our fourth and final session of U.S. Health Best Practices for MENA Transformation. Today, the discussion is going to be specifically on care pathways. My name is Robert Granger, and I am the President and CEO of Nautical Health. It has been a pleasure for the last few weeks to be spending time talking about various ideas that we can take from best practices from the United States and help in the MENA region, including our beloved Kingdom of Saudi Arabia, in transforming healthcare. So, with no further ado, we're going to get started. But before I do so, wanted to just ask if there's anybody from the King Saud University faculty that wanted to make any introductions or say anything before we dive into today's discussion.
Yes, hello, Mr. Robert. My name is Ari Joshloui. I'm a member of the iSport KSU student chapter. I'll be your moderator for today's session. Welcome and thank you for joining us today.
Thank you so much, and it's a pleasure to meet you all. So, just a little bit about myself before we dive into the discussion. As I said before, my name is Robert Granger. My background is primarily in U.S. public health as well as healthcare reform. And in my journeys, I've been a strategic advisor to help with implementation for health plans, hospital systems, and government agencies. One of the things that we do at Nautical Health is we don't just spend our time doing the strategic planning. Our business is implementation. So we take strategies and we implement them so that teams, whether they're clinical or non-clinical, they actually have workflows to see health transformation happen on the ground in real time with their patients. And now we're spreading to the MENA region where targeting we're going to state countries like Oman, Saudi Arabia, as well as Qatar to help transform under Vision 2030 and other aligned initiatives. So today's topic is going to focus primarily on care pathways. And to get started, we just wanted to give out a generic definition of what a care pathway is. And it's simply a structured clinical or operational workflow that guides coordinated patient care across the healthcare continuum. A quick and dirty way to think about what a care pathway is a way of thinking about all the necessary steps that a patient needs in order to have better access to care or to improve the way that they navigate the healthcare system in order to improve healthcare outcomes. These are important for a couple of reasons. The first one, as you already know, specifically in Saudi Arabia, is that you have the Saudi Arabia Vision 2030, and these goals align with both healthcare quality, efficiency, as well as digital transformation. But it's also about prevention and making sure that your country and other meaning countries have a appropriate transition to value-based care models, as well as a way to strengthen coordination between the providers, pharmacists, care managers, and other support vessels that exist in your healthcare continuum. Now, there are dozens of healthcare pathways that we can discuss for today, but I want to focus on six critical that I think that every single country should and try their best to develop best practices around. And the first three are the most critical, and the second three are more emerging. So the first three are chronic care management, transitional care management, and emergency department diversion. So, very briefly, chronic care management is going to be the month over month care pathway that helps patients with chronic diseases to manage it. And the hopes is that through the management, you'll reduce ER utilizations and the need to go to a hospital. The second one is transitional care management, or TCM for short. This is going to be the work that helps patients that are being discharged from the hospital to be in better coordination with their primary care provider, any specialist, and making sure that their transition out of the hospital is one that will not result in them going back to the hospital. And then finally, on this slide, emergency department diversion, or ED diversion for short, is where you redirect patients that are going to the ER for non-urgent reasons that a primary care physician can actually address. And these could be such reasons as a fever or a common cold. These are particular issues that are better addressed in an urgent care or primary care setting, not an ED where it's going to be more expensive as well as it drives up healthcare costs. Then next, we'll move on to some of the more critical emerging care pathways. One of them being pre-palliative care. This is where you identify high risk patients or those patients that are seriously ill and they are starting to move from manageable into a state of more terminal illness. It's important to identify these patients early because once again, you have the opportunity to reduce the cost of care, but you also get the opportunity to engage the family members of these patients to ensure that they're comfortable, that you're managing pain, and that you're not necessarily utilizing all of these healthcare services when this individual has really moved more into a chronic illness space. Now, this is a tricky subject for a lot of organizations, but I will say that planning this early is critical to make sure that the family is comfortable, the patient is comfortable, and that you have the right clinicians aligned with this patient. Next is one that everyone is getting really excited about in the United States, which is integrating behavioral health into primary care. So, simply put, patients have the opportunity to get behavioral health screenings to get the initial intervention, as well as to get coordinated with a behavioral health practitioner while they're in a primary care visit with their clinician. This is very essential because we know that there's a strong association between patients that have obesity and continuous chronic diseases and depression and other behavioral health issues. So the whole goal here is that it starts with a screening, and then from a screening, you have social workers and behavioral health clinicians that you can then do a warm handoff to those patients. And then finally, one that gets many people excited, particularly large pharmaceutical industries and pharmacies, is patient navigation in the actual pharmacy itself. So, as we know, some patients do not go to their primary care physician as often as they should, and they use the ED as well as hospitals as a mechanism for primary care. But one way that we can actually create a new intervention is by actually doing patient navigation at the pharmacy. And that's by identifying some of the barriers to care, making sure the patients are taking their medications regularly, connecting them to the primary care physician, as well as providing certain forms of health education on site. Now, this is a newer intervention, but it's one that is very important as we're looking at ways to make sure that we're keeping patients out of the ED, but at the same time, making sure that patients are integrated into a greater health model, and that includes having connections to a primary care. When I think particularly about the Kingdom of Saudi Arabia being such a vast country in the Middle East, it's really important to consider that as you're moving into rural settings, that oftentimes patients may not have direct access to a primary care physician or a hospital. But if there is a pharmacy, that is yet another vehicle to provide coordination of care. So before we move directly into the workflows, I wanted to spend a little bit of time talking about acuity and why acuity is so important to doing patient care pathways. So on the screen, you have a triangle, and at the base of the triangle is represents the patients that have a lower risk, meaning that they don't typically need many interventions outside of a basic primary care visit. And these are typically patients that are well managed. They may only have one disease. They go to their primary care physician pretty regularly, or they may have a caregiver that's really good at managing their care. So these patients are not going to be as prioritized as medium and high risk patients. And so to dive a little bit deeper, medium patients are going to be those that have comorbidity. So you're starting to see two or more chronic diseases. They may be a high utilizer, meaning that they go to the primary care physician, but they also go to the ED a lot. They may have a recent admission to a hospital, or they may have a relationship with their primary care physician, but they actually don't go to those appointments. So they are identified as a no show. And then at the top of the pyramid is the patients with the highest priorities. Those are going to be those that have high risk, they're high cost, perhaps they're non compliant, or they're in a post-acute setting, which means that they just got discharged from surgery or from the hospital, and they are particularly medically vulnerable at this time. So, in general, when you're thinking about acuity, the whole goal is that you want to prioritize the patients that really need this, and that is going to be valuable to making sure that you're spending the resources for these care pathways as efficiently as possible. So, for example, most care pathway teams may not consist of more than about 8 people. And so, if there's a patient population in a particular clinic or a hospital that is greater than 500 patients, you can't possibly see all of those patients. So, using acuity scaling is really important to make sure that you are identifying the right patient based on the type of intervention that you're seeking to produce. Another critical point that I need to make here is that acuity scaling can be done using population health tools. So it's not easy to manually look at a patient list and determine who is at what level of acuity. So there are tools out there on the market, including a tool that I love that is provided by a company called Milliman Med Insights that allows you to identify these patients and to start to block them into high, medium, and low risk. Now, with that being said, we're going to move into the chronic care management workflow first. So, chronic care management inside of the United States is actually a billable service for Medicare patients that have a fee for service plan. So, providers that do this inside of their clinic can actually receive an additional reimbursement. Now, the first step in chronic care management is making sure that you identify the patients that are eligible. In general, this is going to be a patient with 2 or more chronic diseases that are persistent. They have a recommendation from their primary care provider, and that the patient actually has a need for a care plan. Next, you're going to do an intake. This is where the patient provides consent and our registered nurse provides all of the information about the patient into that particular chart. Next is a care plan is going to be developed, and this is also where you have your health coaching opportunity is produced. This is where you're going to help explain the management of a disease such as diabetes, make sure that patients have its medication, as well as the patient has a plan of action of how they're going to be introduced to their primary care physician and even specialists if need be. You're then going to make sure that you have consent. This is particularly important for those chronic care management programs that are billable. And then finally, you're going to do a 30-day review. And this is where you coordinate with the PCPs and any specialists to see the progress of the patient, as well as determining whether or not the patient needs to be in the program for an additional 30 days or exactly how long the patient needs to be in the program altogether. So next, we're going to move into transitional care management. Now, transitional care management, or TCM, is delivered a lot of different ways depending on the organization. In general, it all starts when the patient is inside of the hospital, and this is prior to discharge. To kind of paraphrase these 8 very dynamic steps, I'm just simply going to say that the cornerstone of this intervention starts with making sure that the patient has direct contact with their primary care provider. This is where we make sure that you get the primary care visit scheduled. You also make sure that the primary care provider is coordinating with the RNs inside of the hospital to ensure that their discharge plans are in alignment with what the PCP would want to see. This is where you also go ahead and schedule the patient for their primary care visit post discharge. You make sure that the patient has a care plan set up and you deliver any type of coaching. You also make sure during this time that the patient has any additional paperwork that's needed before they leave. And then you move into more of the post discharge part of this workflow when the patient is out of the hospital, where you're making sure that they make their appointment. The registered nurse is calling on a biweekly basis to discharge to make sure that their post-discharge experience is positive. They're triaging their pain. They're also making sure that the patient is taking their medications regularly and you're offering a medication review. They're going to see their primary care physician. And then finally, these patients are typically followed more intensely than a chronic care management patient. And generally, they are followed in 90-day waves. And so after that 90 days, if the patient is still fairly sick, you want to follow them for additional time. But this is usually something that is discussed with the nurses, the specialists, as well as the patient's primary care physician. Next, we have ED diversion. And just a little known fact, ED diversion was actually where I started my career in value-based care. So the goal of ED diversion is simply to divert the patients that are going into the ED for reasons that are non-urgent. So once again, colds, flus, a patient that may have a UTI, anything that really could be managed in a primary care setting and they do not need to be in an emergency department, what qualifies ED diversion. Now, there's one important piece of legislation, particularly in the United States, but I would assume that everyone has to take this into consideration no matter where you live, and that's the important fact that you should not be denying any patient care from any care setting. So the goal of ED diversion is not to deny the patient care. It is to make sure that we're educating the patient while they're at the ER so that they're not going back for these particular regions. There are a lot of electronic health records that do that for you. You can actually build markers that identify fevers, UTIs, common colds, and they'll flag it in the chart for you. Next, step number two is, like I said before, allowing the patient to actually experience their regular ED visit, and that includes being triaged and then set into their ED room. While the patient is in the ED room, after they've saw that initial nurse that has taken vitals, then you can go in and offer them health education based on ambulatory care sensitive conditions. These are basically what those non-urgent conditions are called, letting them know how that they can manage them at home, as well as giving them information on when they should go and see a PCP. The fourth and final step of this process is very simple, and that's helping a patient to schedule an appointment with their primary care provider. In some cases, the patient may actually not be aligned with the primary provider, so you may have to have a list of a primary care provider that's accepting appointments so that you have the ability to get them aligned with the PCP. Now, little known fact about ED diversion, it actually creates additional revenue cycle for primary care that may be affiliated with the hospital system. Here's why. Some of these patients that are going to the ED have not had a relationship with a PCP yet. So there's a lot of billable opportunities, including chronic care management, that have never been billed because they've never been inside of a PCP on a regular basis. So by pushing ED diversion in a hospital, you're actually creating revenue for the primary care physicians and their practices. And I can tell you from my own personal experience working at Children's National Medical Center in Washington, D.C., that when primary care doctors figured out that I had this program inaugurated, many of them wanted to have lunch with me because they knew the importance of taking this intervention and creating a referral pipeline with it for that very same reason. So next, we're going to talk a little bit about pre-palliative care. Now, this is a contemporary pathway that is really important, especially for countries that are looking at value-based care. They're looking at ways to reduce costs, also looking at ways to better engage their aging population. So there's primarily two critical steps in a pre-palliative care pathway. The first step is basically looking at ways to identify who these patients are. And this is tricky because it's one part disease management, it's one part family status, it's one part looking at things like frailty codes. So I'm going to kind of go through this list really quick. It's really important to understand that it's not just a patient needing one thing, but it's a combination of things that helps you to assess the total health and the total direction of care for that particular patient. So patients with end-stage renal disease, individuals that have more managed diseases, patients that are non-compliant under a long-term period of time, patients that have serious mobility issues and cannot get around, patients that are morbidly obese, so therefore they're having a lot of issues with bed soring and things of that nature, patients that have frailty codes, which means that they may fall a lot, progressive dementia, patients that have a family preference that they start to go to less appointments because it's just harder to get them around and they're not seeing an improvement in their care, as well as patients that have social barriers. So a combination of all of these with a progressive amount of documentation in the patient chart that signals that the patient is not getting better and that their health is deteriorating makes a state for pre-palliative care. Now, to be very clear, what separates palliative care from pre-palliative care is that this patient is not considered terminally ill yet, but they're definitely heading in that direction, and the family and the physicians want to be aggressive in managing this patient so that you can have better choices and no one is taken by surprise when health starts to really deteriorate. Now, from a value-based care perspective, this reduces healthcare costs. The patient is not in and out of the hospital. The patient is not in and out of the ED room. You're really creating a pre-palliative care pathway that helps these patients to be managed at home, which goes to the next step, which is basically establishing a panel that can be managed through home care, through concierge plans, where instead of there being so many times that the patient has to go into the medical clinic, you are providing a combination of remote visits as well as home visits and even telephonic visits to make sure that the family gets what they need, the patient remains comfortable, and that they can actually remain at home as much as possible. Next is behavioral health integration. So we all know that behavioral health comes with a lot of barriers, and traditionally, the behavioral health side of the healthcare system is siloed from the primary care. But when you are a patient, particularly a patient that has persistent behavioral health issues, it's really important for them to be able to engage with their primary care physician and a behavioral health professional under the same roof. So in general, the generic steps for this workflow are very simple and straightforward. You start off by allowing the patient to complete the behavioral health screenings during the intake of their regular doctor's appointments. In most cases, behavioral health screenings such as the expert and the PHQ-9 are generally administered inside of the primary care's office anyway. So this is just not a deviation from the workflow that's normally going to happen. Next, the care team performs the general assessments that they would usually perform in terms of symptoms, review of systems, as well as looking at their care goals. Then the provider introduces us a new way of supporting care and care goals that involve behavioral health. From there, you have a care coordinator that goes in and brings together the behavioral health specialist that helps them to integrate into that particular visit, and then you continue to manage those symptoms, those behavioral health symptoms, rather with the behavioral health professional or outside of the clinic. Finally, we have the use of the patient navigation inside of the pharmacy. Now, this is a really important type of pathway, as we said before, because it provides an opportunity for patients to get access to care without actually having to be inside of a clinical setting. We're going to find that as populations grow in different cities, as well as there's a need for more and more primary care physicians, that these type of models are going to become very vital and to make sure that everybody has an entry point into the healthcare system. So in general, the patients would be screened based on the medications that they're taking, as well as their care coordination barriers while they're going to pick up their prescription. Then you would have an opportunity to identify any type of issues that the patient would have, such as non-adherence, if they're going to the ED or the hospital too much, or if they're missing any type of follow-up appointments. Next, you would coordinate with primary care, with any type of care management team. You have the opportunity to offer health education, as well as any other type of community-based services. The next step is that the navigator would then follow up by scheduling and confirming a follow-up appointment if there is not one. You would make sure that the patient has access to their medication and that they're taking it correctly, as well as they offer the patient an opportunity to develop a care plan. And then finally, you track these outcomes, particularly focusing on refill adherence, closing care gaps, and making sure that the patients are attending their follow-up appointments. So once again, these type of contemporary care pathways are just very critical into making sure that patients get access to care, that they get the care that they need, and that they have an opportunity to then be pipelined to primary care. So some of the key takeaways from this conversation today is as follows. Number one, care pathways are very essential to improving health outcomes and making sure that you're reducing utilization. And then number two, implementing care pathways require more than just a strategic plan. You really have to get down to the workflow level, as we took the time to go over in today's discussion. So practical next steps for an organization that's thinking about implementing these or any other care plan. Number one, you want to determine the highest strategic priorities for your organization. So one organization may want to focus more on reducing ED visits, where another organization may want to increase revenue cycle and they want to focus on chronic care management because that pipelines patients inside of the primary care visit in order to establish care, establish relationships, and then increase billable opportunities. Second thing is that you want to identify the patients that are most in need of the intervention. And as I said before, you can do this by acuity scaling, and there are several population health tools and electronic health records that help you with this particular process. Next, you want to work with subject matter experts that will help you align these care pathways to your current practices, as well as align them with workflows that may already be in your organization. And then finally, you want to monitor for adoption, volume performance, as well as patient outcomes. By way of career pathways for those individuals that may find these interventions interesting and they want to build a career around it. A couple titles that are really essential to think about is patient navigators. So these would be used primarily in settings where you're diverting a patient back into a primary care setting, and that would be like the example of doing the intervention inside of the pharmacy. You have practice transformation specialists that are going to be the individuals designing the workflows, healthcare consultants that are going to take the deeper dive into developing these programs, and then nursing advisors. These are going to be the individuals that are going to hone in specifically on the disease management side of the house to make sure that the interventions that are being done are in line with what the primary care providers and the specialists would want. So as we conclude this series, I wanted to make sure that everybody has an opportunity to get a certificate of completion. It's very important for us to get a official notation of those individuals that have been a part of the training. And so we're going to do that through the survey. So you have an opportunity to scan the QR code now. It's going to populate a survey. Please fill that out. And those individuals that have filled out the survey, We'll extract your name as well as your email address. You'll receive a certificate of completion from us, and we'll also make sure that the faculty and staff of King Saud University also gets a copy of those certificates of completion as well. So I give a few moments for you to scan, but don't worry, we'll also send out an email that will have the link to complete the survey, as well as we'll have an opportunity for you all to receive this very presentation that'll have the QR code in it as well. So I'll give you a couple more moments to scan with your smartphones, and then we'll progress.
Thank you, Robert, for your practical and insightful presentation. As everyone is taking their moment to scan the barcode, I think we have a few questions in the chat box. But first of all, I want to drop a few questions and then we'll go back to the chat box.
Okay.
Is that all right? Okay. So, Mr. Robert, from your work bridging the US model to MENA market, what's one element of US value-based care that does not actually translate well here? And what should MENA leaders do instead?
Okay. Good question. I think that one element that does not translate well in the United States is that we are so health insurance centric. So everything that we do in the United States is based on the type of health insurance that a patient has. I do not think that it's going to translate well in the MENA region for a couple reasons. Number one, not every MENA region has health insurance for every single person in the general population. Number two is that I believe that Vision 2030, for example, in Saudi Arabia, is one that seeks to develop strategies as well as to see health outcomes that are specific for the entire population. So attacking care pathways, attacking interventions that touches the broader population instead of it being siloed to just what type of insurance type you have, what age group you're in, is going to be better for allowing you to transform healthcare quicker.
Sounds good. Now, I think Prof. Mira is asking a question regarding one of the slides. Is a pre-palliative care covered by insurance?
So that's a very good question. The quick way to answer that question is that yes, most health insurance companies have carve outs for those patients that are becoming more sicker, and they want to give organizations, including the primary care providers, an opportunity to move them into method of managing the patient without having to send them to too many specialists or going inside of the hospital. Generally, how this is done is through an increased bill code for the primary care physicians. So when a patient is really sick and they've been well documented, instead of the primary care visit being like $300, they're going to reimburse the provider $600 to $800 for that visit. And so that difference and the cost of that visit is really going to make the additional revenue that you would want to see for palliative care. But health insurance companies are always very excited for these types of programs and very willing to negotiate.
I think now we have moved on from the insurance pathway section. Mohammed is asking, in the US, how real is the role of patient engagement and the patient voice in value-based care pathways and transitional care management? I think this is very important, especially here in Saudi. This is becoming a major topic right now.
Yes, and I would agree. So here's what I would say. The role that a patient plays in value-based care as well as care pathways has everything to do with compliance. So if a patient doesn't want chronic care management, or if a patient is not interested in going to see their primary care physician on a regular basis, we know two things is true. Number one, they're likely going to go to the ED. And number two, they're likely not going to manage their care well. For these two reasons alone, patient satisfaction is really important in the United States, whether we want to focus on it or not. So, some general steps to kind of help people frame how to make sure that patient satisfaction is brought into the fold of planning is number one, having focus groups with patients. Number two, engaging caregivers. This is going to be the person that's going to be that intermediary or the advocate. Number three, making sure that patients always have consent in care pathways or any type of interventions that you're going to bring them a part of. And number four, that you're taking the time to explain to a patient thoroughly what's happening in their care. That's why I personally believe and endorse the idea that every single patient needs to have a care plan, even if they're not chronically ill. Just taking the time to write a little note and to let the patient know what the doctor thinks the patient needs to be focusing on for the next 3 to 6 months is a really good way to lay a foundation for what the patient needs and to get the patient's involvement in writing that care plan so that it feels like something that's more collaborative instead of something that is being pushed on a patient.
Robert, do you think patient-reported outcomes, PROMs and PRIMs can be the best tool in this situation?
Yes and no. So they're valuable, but I will say as an operational and implementation consultant that I like to tell both government agencies, academia, as well as those individuals that are running hospitals and clinics that you have to have different levels of data and insight to really tell you how well your program is doing. So patient reported outcomes is one piece, but you also have to think about things like productivity of your staff. You have to think about the burnout of providers. You have to think about the frequency that a patient is coming in and out of your clinics or your hospitals. All of these things combined give you a better story of what decisions need to make, what things are working well, what things are not working well, and how do you move from strategy to workflows, and then from workflows to revising those workflows.
Perfect. And now I think we have, I believe, in one final question from Prof. Bender. He's asking if a private and public healthcare system has defined the value differently, and if so, does this make it difficult to apply the same high value care pathways across both?
Unfortunately, the answer is yes. However, I do believe that the MENA region has an opportunity to bridge that gap through by pieces of legislation and regulations that come out of the Ministry of Health. So if you make care pathways mandatory, if you make things like creating workflows that ensure that patients transition out of the hospital well and that patients have care plans if they have two or more chronic diseases. If that's done at the top, then what happens is that it makes sure that that primary care offices and hospitals that are private, they abide by this and that they actually prioritize it. What I can say is that public systems typically are more government funded or grant funded, so they're going to naturally be able to align with these. But when you are private, there is a push for revenue cycles because they want to make a profit. Taking this into consideration, as long as the government is helping to guide what private organizations are doing, you can most definitely make sure that these care pathways are prioritized and that they also have guidance on how you can make sure that these things are actually implemented.
I think this wraps our question from the audience, but I do have one question. I believe this is going to be the cherry on the top. Mr. Roberts, in your experience working with the US federal agencies, what is the single biggest mistake health system can make when first trying to implement care pathways, especially that here in Saudi, we're under a major transformation in our healthcare system. So we would like to learn from your experience.
Thank you so much for that. So here's what I'll say. Many organizations put a lot of energy and they give a lot of excitement at the level of government mandate. They give a little bit less excitement when it's time to do the strategic planning. But when it comes to the actual workflow development, and you start to ask the questions like what the nurse's workflow is going to look like, how is this going to impact the providers? How are people documenting inside of the electronic medical record? All of those implementation cues are oftentimes forgotten or they're not given the same level of time, money, resources, and coordination to make sure that it matches that same level of insight and excitement that people have when talking about it in a boardroom or when it comes out in a government mandate. So it's very critical that when organizations want to do well with care pathway implementation, that you have to give yourself the time to plan these things out adequately, that you're consulting with subject matter experts that have done this, and that you're really thinking about what story you want to tell and make sure that you have that appropriate buy-in from everybody that's on the clinical team, not only the nurses and the physicians, but those people that are doing check-in at the front, even the individuals that are cleaning and stocking the exam rooms. It impacts all of them. And so you want to be able to take into consideration how it's impacting them and how you can make sure that it's going to be sustainable.
Now, I think we have one additional question. This discussion actually is very insightful. So, Prof. Munir is asking how are medication refills handled within the value-based care pathways and transitional care management? And do these pathways actually improve the refill process for patients?
Absolutely. So, first and foremost, thank you for asking that question. I love when people start to take the concepts that we discuss and really start to break them down into pragmatic ways of implementing. So that shows that he is well on his way to being an healthcare administrator at some point. But to answer that question, inside when you're thinking about medication refills, the first thing that comes to mind that's really important in value-based care is thinking about medication formularies. And so formularies is nothing more than a tiering system of filling prescriptions for a patient based on cost and based on need. So in general, you want to always use generics because they're cheaper and these are more standardized medications. And then as you move up into a second tier or a third tier, these are going to be medications that are more expensive and require a higher level of documentation and likely trial and error with generics before you would progress up the tiering. So that's really important to take into consideration when we're doing this type of work. Um, Now moving on to talk a little bit more about like generically pharmacy integration and prescription filling. Couple things to note. Number one, medication reconciliation is a critical element of every patient way that you develop. This is really important to note for a couple reasons. Number one is that medication is a huge line item when it comes to value-based care and reducing healthcare costs. But secondly, the medication compliance is one of the easiest ways to identify when a patient health is either waning or is actually improving. So I know that many of you are pharmacists. This is why it's so important that clinical pathways that involve pharmacists is something that is recognized by the Ministry of Health. It's endorsed by academic institutions like King Saud University, and then are implemented in both public and private organizations.
I believe we don't have any more questions. Thank you, Mr. Robert. This talk have been very insightful. I believe for the audience as well as to me, Now we can, to everyone actually listening and watching, the question now is no longer if care pathways and value strategies will come to MENA region. Now the question is who will lead them, how they will lead them. The tool exists, the evidence exists. The only missing piece is the will to start and implement effectively. So thank you, Robert, for your talk today. I enjoyed it as much as everyone has enjoyed it. We will see you soon, inshallah.
Thank you. So just one final note.
Of
As
course.
soon as things get a little more easier to in the region, we are seeking to come over with the intention of doing two things in partnership with King Saud in person. The first one would be in-person training for those students that are looking at all of these different value-based care initiatives and figuring out how they can plan careers about it, what certifications they need, what organizations are available and in the United States that would be interested in having you shadow for a couple of weeks inside of the United States. So we want to have something in person with the students that can really just take these conversations to the next level in terms of career planning. And then finally, for those individuals that are either in academia, in government, or you actually manage a hospital or medical clinic at an executive level, we want to have an executive roundtable for those individuals that gives you the opportunity to talk more strategically about what would be those next steps. So as soon as we get more clearance from the U.S. Embassy, we're going to work with Dr. Bander to figure out what those dates would look like. But we're really excited to do this, and we've truly enjoyed this opportunity. I know that personally, I've had a surgery, I've had 3 deaths in the family. We also had Ramadan, but through it all, I think that this has been a great and exciting webinar. And I'm so excited to be in partnership with all of you and to also see the growth, even in the questions that you've asked doing these 3 or 4 interventions. So with that in mind, I did have some resources that you all will be able to scan when you get the copy of the presentation.
Thank you, Robert. Of course, the future will hold valuable collaboration, and we're very excited to meet you in person.
Thank you. We also have our general contact information here, and we'll end with that. So if you want to scan for a meeting or to start a project or just to send us a note or have questions, please do so. I will hang out for another minute or so. And other than that, thank you all so much for joining us today.
Thank you, everyone, for joining us today. Thank you, Robert. I will see you in person soon, inshallah.
Thank you, inshallah.